This is Shift Happens. And today's episode, we are talking about women's health. And really, we're focusing on the huge gap that exists in healthcare for women and how we're treated, but especially those of us who are past our childbearing years. I've spoken to in the past on some of my Instagram and, of course, with some of my colleagues and my staff about the fact that when I knew I was done having children, I was not. I didn't feel very included in the obstetric and gynecologic world, right?
Mm-hmm.
I feel like people are really good at delivering babies sometimes, but sometimes they're terrible at gynecologic surgery.
Mm-hmm.
And then what's even worse is that when I started having symptoms that I could tell was related to my hormones, I went to my primary care, and of course I'm like, hey, I'm having anxiety, I'm having brain fog, my libido is in the toilet. And she was like, here's an SSRI, here's some Zoloft. This is a normal part of aging. This is expected. And again, I know that I'm going to age, but I'm not okay with expecting to accept that it has to be a miserable experience.
Mm-hmm.
And it's the same thing with any treatments that we do in healthcare. I don't think that women should just grin and bear it while someone's like, scraping pieces of my uterus out of my vagina, right?
Mm-hmm.
So this is what I want to talk about today. So let's talk about who I have with me today. To my left is actually my sister. She is a nurse specializing in oncology, but she's also experiencing menopausal symptoms, which she's agreed to actually talk about today. Next to her is her daughter, which is my niece, but also an actual physician's associate in obstetrics and gynecology. So she's boots on the ground in this field, and I've had the pleasure of hearing her transition through her own experiences, and she's kind of evolving with this evolution that's happening with women's health as well.
Mm-hmm.
And then finally, Christine, as some of you may know, she's my nurse practitioner here at the Injectory, and she's very passionate about women's health, and I'm hoping that we have a meaningful conversation that is also productive, but also allows us as women, let's talk about it, right?
Mm-hmm.
If we don't talk about it, then nobody's talking about it. And if we don't put ourselves out there, like we need to be, putting ourselves out there saying, I'm having symptoms, I'm not happy with how I'm feeling, and it's okay to talk about it. We need to be champions for ourselves and for each other. Mm-hmm. So, let's kind of talk about the current state of women's health. Harvard recently discussed that a new specialty might evolve in women's health, and that includes aging women, right? Menopause, mm-hmm. things like that. And, it was Taylor who actually told me this.
Yeah.
So, yeah, you went to a Harvard conference?
Yeah, so I went to a Harvard conference in March, and it was really informative in terms of how we're really starting to realize that when we combine specialties such as OB/GYN, and we're really starting to ignore some of the parts that gynecology really needs an emphasis in, right? And so it's really nice that we're seeing like our top, authors of even up to date mention like they are not having enough time to fully train some of their doctors in OB/GYN. And so I really am bringing that up kind of in the sense that I really want women to feel like I think medicine has been lacking, but we're going in a positive future, towards women's health. And I think being graceful while we're kind of going through this research is really important. But also, I think the point is just listening to the patients is such a good first step.
Yeah.
I can't tell you, like, just from when they walk in the door, you can tell they're hesitant, and so it's not something that I think us women were allowed to talk about, so I really love this field purely because you get to really take that on and listen to the patient and adjust their treatment plan for them,
Right. Well, when you first started in gynecology, I remember you saying to me, you 40-year-old women, you're my toughest patients. And now,
Yeah.
now that you've seen most of us, what you're realizing is that we were tough. Us 40-year-olds were tough because we were frustrated.
Yeah.
And the truth is, there's no true protocol for perimenopause.
Yeah.
Right. Dr. Marie Claire Harver, she's kind of like an up and coming face of menopause, as well as now she's researching, writing a book on perimenopause.
Yeah.
And so one of the issues is, first and foremost, I do want to point out that it is my generation, Generation X, millennials, we're the ones who are starting to experience these symptoms, and we're like, no, I don't tell me I have to put up with this. I'm not okay with this. I'm not okay with feeling like crap. Or let's be honest, men, they get a pill for erectile dysfunction. You know, they don't say to them, oh, I'm sorry, sir, but that's part of aging. Your penis just isn't going to work as well. But yeah, we get the, sorry, vagina's dry up. You're not going to sleep well. You're going to sweat. Your joints are going to hurt. You're going to feel crazy. Sorry, that's normal. And that's where my frustration comes from. And I'm so proud of us women finally saying, no, I'm not taking it. But back to Mary Claire, Dr. Mary Claire, she's said a beautiful, like, kind of honest answer, which was that she spent 1 hour in med school talking about menopause and 6 hours in residency talking about menopause. And 1 in 5 obstetrician and gynecologist residents feel prepared to treat menopause when they come out of school. So less than 10% of medical education includes menopause. And so think about an obstetrician. Let's look at them, a gynecologist. They are treating teenagers who don't want to get pregnant, right? STDs, right? These things that happen in that age group. How about with endometriosis? Then look at PCOS. Then let's get into the fact now a woman wants to get pregnant. Now we got to look at her hormones, her ability to conceive, the lining of her uterus. Now let's look at, you know, carrying this pregnancy, making sure this woman, if she has, anemia, if she goes into HELLP syndrome, if she has preeclampsia, if she has just a basic boring pregnancy, right? Then deliver the baby, do it safely. Oh no, we have to C-section her. Now the woman's done having babies. Think about everything that obstetrician and gynecologist has now had to kind of put their head around. And now you're going to go into perimenopausal, crazy-year-old 40-year-olds who are like, I'm done. I'm having irregular bleeding. I'm having cramps. I'm having phantom pain. I'm having my ovaries and my cysts explode. Like, there's all these symptoms, and then you got menopause. So it is a gambit of information, and I think the expectation, which is what Harvard's kind of expressing, is that that's too much information, and we need to start specializing. So, let's let physicians who love to deliver babies and deal with those 18 and 20 and maybe 30-year-olds. And then can you please have a physician for us people who are drying up and getting old, perimenopause and menopause,
Well, also sometimes people don't want kids, and so I think it's also just kind of allowing the environment to allow the patient to talk, develop their own kind of treatment plan, and so you really have to sit down with them and see what their goals are, because you can't, as a provider, decide what's most important to that patient, right? And so my hot flashes are tolerable, but it's really, and
like libido,
right? Or vaginal dryness or urinary symptoms, like it's really kind of trying to target what is most uncomfortable for them, because I was picking on you because you're my aunt, and I love you, but I just feel like, I think it's shifting the mentality again, just the idea of listening and allowing that environment for that patient to talk. And I think it's also, as practitioners, I don't think that, women are properly educated about perimenopause, about their own bodies, so they don't even know their symptoms are attached to perimenopause, right? So I think one of my approaches that I've shifted in, my first couple of years of being a PA was starting to list out what the most common symptoms that these patients are experiencing, because there's a certain point where you're realizing we're told that, some practitioners, this is not myself, but they don't want to administer HRT until they've gone through menopause, right? What a gap, in care, in my opinion.
earliest perimenopausal symptoms are occurring at 35 in some women. And so can you imagine being 35, and if the average age for menopause is 51, that is 16 years that you have to go 12 months by the standard medicine practice. You have to go 12 months without a period.
Yeah.
Right. But if you're a woman who went 11 months and you have a period on that 11th month, you got to start that cycle over. And you had mentioned when we were talking about this before this, that at 13 months, they can go and have a period and it kind of resets it, right?
Yeah. Well, and I think this is the idea, right? Our bodies don't listen to our medicine guidelines, you know, and so I will say as a PA, you know, you went more than 12 months, it's considered postmenopausal bleeding, right? I would recommend the workup because I'm always advocating for my patient in terms of if they would like to know something's concerning, such as hyperplasia, you know, cancer, an endometrial biopsy would be indicated at that point. But have I seen it where we did the full workup on a patient and everything was negative, and then turns out I did her blood labs and it really was just her ovary kind of sending that last surge? Yes, you know, and so
Better safe than sorry.
Yeah, exactly. And so in those situations, you know, and we can kind of go over HRT and bleeding and all that good stuff, but I think it's just the idea that kind of what you talked about, they can start developing symptoms as early as 35, right? And so it's really important to take that time to listen to patients, you know, and including even their just bleeding patterns, right? That's sometimes the soonest, you know, symptom that we can observe. And so encouraging them to listen to their bodies, to do little diaries, you know, sometimes with perimenopause, the earlier stage, we actually see bleeding patterns getting closer together and heavier. And so that's the decrease in progesterone that we see in these women, right?
Right.
And so sometimes they really benefit from progesterone options, you know, kind of discussing what they were, what they would like to treat. Maybe it is just the bleeding, you know, let's treat it. Why not? Why suffer, you know, for 15 years? That doesn't make sense, you know?
Right.
And I think that...
But obviously with birth control, right? So like, again, some birth controls are progesterone only. And of course there's estrogen, you know, for birth control as well. So I think that that's part of, I would say, a misconception. When your physician says to you, well, let's put you on birth control, it's not because they want you to control your birth, like, you know, chances. It's actually, we're calling it birth control, but really that's hormone therapy.
Yep.
So I feel like, hey, I'm going to put you on a birth control, but in this case, we're utilizing it as hormone therapy. And I think making that distinction so that patients understand, I'm not making you take birth control again. I'm actually giving it to you because this can help your symptoms. And so I've heard from my friends, God, they want to put me on birth control. My husband's had a vasectomy. I don't want,
or
why
I
am
had a
taking
tubal
this?
ligation, you know, and they're so frustrated, you know, like I got this because I didn't want any more kids. Why do I have to be on birth control, you know? And it's kind of weighing those options with them, you know, having that full encompassing like conversation with them, you know, that's definitely important.
I know that in discussing this, I know that my sister to the left of me isn't a big fan of taking supplements such as hormone therapy, including birth control, I guess to some extent.
I mean, I think when you're younger, you can take things for granted, and I want to keep doing that. And, you know, I'm just finding that I can't really. So I'm having some of the perimenopausal symptoms, and I think more because I'm aware of them. And I have to do all the things that can try to reduce those symptoms, like regular exercise, eating healthy. But despite that, you know, we're going to get older. And so I'm thankful that I have my daughter to kind of run things by.
Let you know you're having a hot flash. Like, Mom, you're actually having a hot flash right
my
now.
first hot flash was in the car, and my husband runs hot anyway. And
You run cold, though. You
always
cold.
usually,
So I turned at him, like, upset. I said, did you just turn on
like she
the
woke
car seat
up
heater?
from like dead of sleep,
Yeah,
by
I
the
thought he
way,
turned the
like
heater
in
on.
the AC car
and I
on the way
was kind
down.
of upset, like, why are you turning the heater on? He's like, the car seat heater is not on. And I think about it for just a second, realizing, oh, I just had a hot flash. That was so weird.
And she was skeptical. She actually looked at the like the little dial at the bottom. Yeah,
he's sabotaging you.
Yeah, I don't know. Just touch it by mistake would probably be the biggest thing I would think of.
Are you struggling with the reality that this is like that you're likely hitting that perimenopause
Yeah,
slash
because I'm
menopause
kind of in
symptoms?
the exercise regularly, eat healthy. I just need to do that to kind of avoid those symptoms and a little bit of denial to be truthful.
Yeah, see, and I'm over here like I'm not like if I have hot flash or again whatever symptoms I'm having, I'm like, how do I fix this?
Well,
Because I'm a fixer.
That's why you do things like this, because I think for myself, I keep thinking if I just eat healthier, I won't have that weight gain. Or if I just exercise more regularly, it's because it's really because I'm not exercising regularly. It's not because I'm going through the hormone changes and I'm sleep deprived. I don't feel like exercising. I'm irritable, and I think
she's very irritable. I'd like that.
Oh,
I'd like to put that on the record.
I like to think. I am telling people at work I'm getting old and crotchety, and then I just say it as it is. And my younger self would be listening and more quiet. I'm just naturally on the quiet side, opposite of my sister.
People were always surprised when we were growing up. They're like, your sister doesn't talk, and I'm like, she does. She just doesn't talk like in public.
Yeah. But now I think. There is some irritability where I just will say the thing, like, stop doing that. That is not okay. And whereas my younger self might, like maybe not say anything or.
Are you saying that when you were younger, you were more polite? Is that what
I
you're
was
saying?
Yeah. Sleep deprivation and.
But we actually. So this is one of the misconceptions is that for one, they act like women gaining weight in their midsection is again a normal thing, and they're literally like exercise. Well, first off. You cannot eat or exercise yourself out of that change.
I'm in denial.
Yeah. Well, I would say Regina's been the same size her entire life, and I remember her recently getting frustrated because she runs all the time. She literally she won't have Starbucks because it's calories. If she has a piece of pizza, she'll live on a yogurt the next day.
I can.
It has the runner diet, or especially for training.
She's a very mediator of like what she
runner,
eats.
You don't have to have the cup, the little belly, the lower belly, because you're running on a regular basis. I feel very fortunate to be able to say that. But now, some perimenopause, I feel like I can cup my lower stomach and around my kidneys.
You have a pooch. You're saying you've developed a pooch,
yeah,
and you have this flat stomach.
There you go.
The love-handled pants are not, anymore.
But the truth is that so many providers are still telling these women, well, you need to exercise more. You need to watch what you eat.
Which is not the case. Yeah. I mean, you can't outrun this stage of your life. I mean, all of us are going to go through it, right? And so it's just more. But I also think, I think it's a great input of, having this perspective is really addressing lifestyle modifications too. I'm not saying those are bad things. We're at an increased risk of high cholesterol, and cardiovascular diseases. So exercise, great, But I think it's also addressing what can we adjust in your diet to lessen the amount of hot flashes, like caffeine. Spicy foods. You can't imagine the amount of people alcohol, wine. Everyone likes a nice glass of wine, at least I do, but it's this idea of really addressing those different things, because I don't want to preach to the choir. I don't want to call out my patients or any of that sort. It's just trying to see what would make them feel more comfortable, right? And so if they're able to tolerate these symptoms, fine, that's up to them. But if you want to do something about it, here's the space or in the conversation to do something.
I think that the reality is that some people, so we all look at everything like risk and benefits, right? We all decide, if I want to have that glass of wine or two, then maybe I'll adjust my diet. Or maybe you're like, you know what? I'm not going anywhere. I can have a glass of wine. So if I start flashing tonight, I'll just deal with it, right? I'll just buy one of those mattress covers, the little cooling mattress covers. There's all these little things you can do. But I think that what people aren't understanding is that one, first off, there's 60 symptoms for menopause, for perimenopause. And we really downplay it. I actually didn't know until I started researching this 2 years ago when I decided that I wasn't going to just accept that Zoloft was the answer to all my symptoms, because it wasn't. It wasn't going to solve my symptoms.
Which is so hard, by the way.
I think there's a place for that, right? Like you say.
Yeah. Well, and maybe, I've had patients make that decision. I'm getting so frustrated. My anxiety's out, my depression, all of these things. Yeah, irritability.
I don't want to downplay the people that do decide on that.
Oh no, I still took the Zoloft. I am way less irritable.
Yeah.
But when I went back for my follow-up, they were like, oh, well, how are your symptoms? I was like, to be honest with you, I don't feel like I'm snapping at people as much. It has helped. Because the truth is, there are symptoms that can be
Overlap.
managed with, exactly. So, and I do want to point out that anxiety is not bad. It's actually productive.
Well, a healthy anxiety, it can get unhealthy.
Yes, right.
Yeah.
It's when
Finding the
anxiety
balance.
negatively affects your life that it becomes problematic, but otherwise it's protective. Anyway, they were like, oh, well, this was just the starting dose. We usually go up. And I was like, no.
Yeah.
Because I know that dose is so related to your side effects. And the other problem is that antidepressants and mood stabilizers can affect weight gain as well as libido. And for me, those are, besides anxiety, those were two of my big symptoms for perimenopause, was this like anxiety, yes, but then I found out I was having all these itises. Like my joints were hurting, I had tendonitis, I had Achilles tendonitis, all these itises. And to find out that's part of perimenopause, right?
But some of those medications aren't just weight gain, right?
Well-
Some of them you cannot.
Well, they're more weight neutral.
Well,
but that
yeah,
doesn't
we
mean
do
that
have like certain SSRIs that are more weight neutral, but most of the time, I think it's when you have a full history in these situations, like really determining what is most important to this woman.
It's your priority,
right.
and the patient's priority. And
Yeah.
like you said.
I think one of the reasons that downplaying these changes that are happening to women, Dr. Mary Claire mentions the zone of chaos. Like when progesterone like starts getting haywire, estrogen's getting haywire, and they're calling it the zone of chaos because nothing is syncing up. If you've ever seen the video of like some of those like specific Asian traffic scenarios where they're like, and you're like, how does no one die every day at this intersection, right? It makes me think of our hormones. Like think of that intersection chaos as what's happening within our bodies. And you have estrogen receptors all over your body, including your brain. And so what's happening, I think, is that women are hitting perimenopause and menopause, and they're feeling anxiety, they're feeling depression, and this is negatively affecting their lives because they're not being told that this is one, normal part of aging. Two, there are ways you can treat your symptoms, and so they're assuming that they're unhappy with their jobs that they loved up until then. They're unhappy in their marriage, which they either tolerated or loved up until then. And you cannot believe this, but 43% of women consider leaving their jobs during menopause. 43%. This is even crazier. 73% of women state the cause of their divorce was their menopause. 73%. So we are seeing a huge rise in either women changing careers or changing their jobs or potentially leaving their marriages. Now, you can't say that menopause is making people divorce. I would say it's one of three things. One, they are kind of, I don't want to say losing their mind, but unable to decipher reality and from what, like, if they're feeling dissatisfied, they're trying to find a reason for it. And they may be looking at their marriage. Now, maybe that is the case. Maybe their marriage was unhappy and now they've lost their filter and they're like, no, don't talk, right? Like maybe they're just not going to put up with it anymore. And that marriage likely would have like ended eventually anyway. However, sometimes your spouses don't actually support you during these changes, right? Some men,
But they don't know how to.
Right.
Yeah. I mean, us women are still learning how to support each other in some ways.
Like, I will say, like, I'm hopeful for some, like, the woman our age, like Taylor and I's age, that, like, it's going to be better by the time we reach that because people are talking about it. There are actually treatments for it. So it's kind of like, I mean, in medicine, prevention versus, like, treatment, but like I'm like, as soon as I'm done having kids, like put me on testosterone. Like if I can help myself ease through that more, and if like the women's health field can like get behind that and support it, like how much better women will feel like throughout that,
Right.
and there not be so much like shame or like taboo-ness around it.
Right, exactly. Yeah, I think that like them talking about perimenopause, I honestly thought that going through menopause was just hot flashes and you could no longer have a baby.
Yeah.
Like, I'll be honest, up until...
Well, it's crazy, just like you're talking about in women's health, like how much, like how undereducated you are. Like friends of mine and my sister, who's now 28, she didn't realize you have 4 parts of your menstrual cycle. Like there are different phases of your menstrual cycle. Like no one teaches you that. No one teaches you can only get pregnant 5 days out of your, like, out of the month. Like, so it's like, you grow up like being so in the dark about these things, you're learning about these things, and then you're getting frustrated because you're like, why did no one tell us about it? And I think that's specifically like for people our age, like that are like, why is this not being discussed? Why was I given a birth control pill to cover up all my issues that I was having? And so I think, I know your generation speaking up about menopause, but I think our generation is speaking up about like, we're not okay with
Knowing
the
your
way
bodies, right?
that like we're being like prescribed things in like Band-Aid fixes in medicine. So
Right. Yeah.
hopefully we're making changes and a positive impact.
Well, you just finished your women's health rotation and your NP clinicals, as well as just finished BioT training in Dallas.
Right.
What were some aha moments for you, I think, in between those two events in the last few months?
In clinicals, I think I learned a lot. I mean, a lot more about perimenopause, like in menopause, and that like you can be in perimenopause in your 30s and that your symptoms, like not to poo-poo like people's symptoms, because people, especially early onset menopause, if you're starting menopause in your 40s, that means in your 30s you're going to be in perimenopause. So that was a big eye-opener I didn't realize. In terms of BioT, I think one of the biggest aha moments was, one, they showed 2 studies, I can't remember what they were, that hormone replacement therapy is actually protective against breast cancer versus causes breast cancer. And what a disservice have that like our healthcare has done for women.
Yeah, and
in
cardiovascular
scaring
health
them.
too.
Yes.
Yeah, it actually
In cognition, they actually mentioned that they have 3 patients that are 100 years old on BioT hormone replacement.
Wow. Well, yeah, so estrogen is all over the body, right? Which includes your brain, and hence why these mental health disorder diagnoses are happening later in life. Later in life, these are happening, including ADHD.
Yeah.
Now, I already know I had ADHD, so I don't even want to know. Y'all thought it was bad before. You just wait. Right? But the truth is that one thing that I think all of us as healthcare providers understand is that neurological function, once it's lost, is very hard to recoup. So it is better to start treating your brain health sooner, and that includes hormones. Because you don't want to lose that function. And the rates of Alzheimer's related to hot flashes. So if you have hot flashes after 60, your chances of Alzheimer's is higher, and your chances of like coronary artery disease and MIs are higher. So why would somebody be having hot flashes past 60? That's kind of unheard of, right?
I mean, I agree with that full-heartedly. You know, I think that needs a further workup in a lot of ways. And even, this is why personally I don't like diagnosing perimenopause with blood work, right?
You can't really.
Well,
It's very
exactly.
difficult.
Yeah. I mean, I've had patients who tell me, oh, they did blood work, you know, and they telling me I'm not in perimenopause, and I'm like, what? You know, like maybe they caught your estrogen, you know, up here, you know, but in the chaos that we're talking about, it's really down here tomorrow, you know, like, and it's just more of that idea of, again, just listening to the patient, right? I mean, listing out these different side effects. I mean, we're talking hot flashes, night sweats, but you have estrogen receptors on your thyroid, on your bowels, you know, like these people are having like IBS and
constipation.
You know, all these different, like.
Can you imagine if you woke up one morning, you didn't sleep well, right? So you're sleep deprived. Your stress level, you can't poo, right?
Bad
you
day.
can't poo. You are soaking in your own sweat. You haven't slept well in so long. You don't feel like yourself. You feel crazy, right? And your cortisol levels are through the roof. You don't want to exercise, like because your cortisol levels are high. You're wanting to self-medicate, so maybe you're drinking more. Maybe you're eating more carbs because your body's trying to hold on to energy,
and you can't
right?
even have sex because the vaginal dryness.
Right, exactly, right.
Nothing to relax.
Exactly. So I mean, but then the truth is that our healthcare society I feel like up until the last year has really been, this is a normal part of aging. I was
Yeah.
working with one of my favorite obstetricians in the OR a few weeks ago, and I asked this physician, because I was curious. I really love what she does in obstetrics. She like holds the baby up for mom to see after C-section, which, by the way, normally they whisk him away and mom's the last person to see him, and she's got to stay there while she's getting sewed up. So I always love that about her, and I happened
She
to
has her
start
own little
asking.
personal-
So I finally I was asking her some questions about perimenopause and menopause, and she poo-pooed it. She said, it's a normal part of aging. And I was like, and I won't be going to you for those symptoms.
yeah.
Here's the thing. Guess what? As an obstetrician, she would have been one I chose. I didn't know her till I was done having kids. But guess what? It is okay to change your physician. It's okay if you've seen somebody like all through your gynecologic and obstetric, like someone you saw as a teenager, and to look at them and be like, thank you so much for what you've done for me, but I need to go find somebody who's willing to respect my needs now.
Yeah.
Right.
And it's okay for that obstetrician to believe what she believes. It's okay for her, because you know what? That's not her specialty. And most likely, the way that things are going, she's probably going to be lumped into the gynecology obstetrics for the fertile ages. And there's going to be somebody out there for me who's going to listen. And weirdly enough, her partner, and again, I don't want to say any names, who actually is embracing hormone therapy. Been doing, honestly, he's delivering babies from babies he delivered. That's how long he's been in gynecology and obstetrics. So for somebody that far into their career to still have plasticity in their practice, I'm so proud of him. And I could go on and on about testosterone therapy, and you all know that, I wanted a space. Thankfully, I have a practice. It's a concierge of sorts. When you come in, we're going to spend time with you. We're going to have all the conversations, and we're going to listen to you, and we're going to focus on relieving some of your symptoms. It's a cash-based basis. So, of course, your insurance isn't involved, but insurance isn't going to cover it. The truth is that insurance guides care in the United States too often. And too often that means that providers can't sit down with you for an hour, hour and a half, right? They need to turn and burn, right?
Yeah, I think that's hard. I mean, coming from an insurance-based practice, it's you are given a certain amount of time that I wish I had so much more to really delve in. But I think how I approach it from my standpoint is, like, if they came in for an annual, but they're listing all of these different things, I'll put in blood work, so we do the full workup, but I actually schedule a follow-up just so we have that time to really fully educate about perimenopause, menopause. And then I encourage them to go out and look into, HRT, what perimenopause is, menopause.
Because you want them to come back informed and be able to have those meaningful conversations.
Absolutely.
You want them to take responsibility as much as, they need to
they need to feel comfortable.
Yeah, exactly.
Yeah,
Informed,
I think
come with questions.
Yeah, and I think kind of what you were touching on is, I think we go into medicine to want to care for the patients, right? We want them to feel comfortable, and so I think just us women really need to advocate for, standing up for yourself, I want them to have a positive experience, and come up with a treatment plan that they feel comfortable with, make those choices. So I like the idea of advocating, because I think women are so amazing. We have so much strength in the idea that we self-sacrifice all of the time. It's so, I'm a mom of 2, and the idea of running sounds amazing, but the time outside of work is so hard, and that's just the time frame I am in now. But we're talking about these major life changes at perimenopause, menopause, and they're finally starting to put themselves first a little bit, and it's okay to,
Well, I always say, if you don't, you cannot give from an empty cup. You've got to take care of yourself. And I think too often in our society, women just go with the flow, and the problem is they act like it's normal. And again, when we talked about in one of our previous episodes about postpartum, right? And we talked about postpartum depression. So imagine you don't really understand it. You just think it's feeling want. It's not. It's believing your baby could die every day and becoming obsessed with it and unable to like sleep because you're like staring at your kid in a crib and thinking something's wrong with you, right? And then feeling there's not a space for you to, and just you're just gonna get through it. It'll go away, right? There's so many things that if we don't talk about it, I think that we don't know that what we're going through is, yes, normal, but you don't have to just deal with it. And this kind of leads into like one of the other conversations I want to have, which is the level of neglect I think that happens to women in healthcare outside of poo-pooing our symptoms and telling us it's normal, is how they actually treat us, especially our pain. So women, it's been proven that women, we have a way higher pain threshold than men. Everyone's seen the videos where they put the TEDs on the men, they do like period contractions.
No
and
idea.
the women are like, oh, that feels like my period. Oh, and like 8 out of 10, like they're 8 out of 10, 10 out of 10, and women are still like, yeah, that's a little uncomfortable. And then the guys are like 4 out of 10, and they're like on the floor crying and screaming, take it off of me. Yeah, exactly. But the problem is that then we're expected to just put up with pain. And so again, this is all about me. No, I went and got an IUD postpartum. I vaginally delivered my twins. I had the IUD put in. I did what they said. I took 800 milligrams of ibuprofen before my appointment. I had the IUD put in. It was a little pinchy, crampy. It reminded me a lot of a pap smear, a little bit longer. And I remember the nurse saying to me afterwards, wow, you did a really great job. A lot of people have a lot of pain. And I was kind of like, yeah, because I consider myself to have a high pain threshold in the sense, like when I work out, I like to hurt. Like after a workout, if I can barely walk, I call it the strut. Where like my legs are so fatigued, I'm like, I can't walk straight. Like that's a good workout for me. I love that. But I just thought, yeah, okay, that's why. Well, then I went back for my next IUD, and now I haven't had a child, and my uterus is like, has nothing has passed through that cervix in quite some time. And I thought I was going to die. It was so uncomfortable. One, I do have an anterior tilt. Two, I know from doing anesthesia that sometimes when they clamp the cervix in some women, they respond. Like it's uncomfortable. So obviously some people's cervix are more sensitive than others. I find that before my period, I am more sore down there. Like even for sex, it becomes a little bit more uncomfortable. Yeah. So they tell you to get it done right before your period because your cervix starts to open up a little bit. Well, I will tell you that I was literally like, because it was so uncomfortable. How much longer? And I remember the nurse that was standing next to me, or it could have been an MA, whatever she was like, are you okay? And I was like, yeah, how much longer? And she was like, and she like rolled her eyes at me. I remember being so pissed off about it. And it was in that moment where because I'm healthcare, I'm kind of like, why did they just do that to me? Why did they not put some local down there? They could have given me some Cervidil and softened my cervix. There's a lot of things they could have done when they saw that it was uncomfortable. But instead they're like, you're fine, almost done. And okay, just so you guys know, actually, Taylor, I'm going to let you tell it. Go through the steps. Because the first one is you got to use the damn dilators, right?
Well, so I will preface this too is like, again, approaching the patient and getting an accurate history is the most important part, right? Having a consult with them and really sitting them down and seeing if they're nulliparous or they haven't had a baby before. That cervix and that uterus is going to be a lot smaller, and so I would advocate listeners or patients, to realize that, because I think the more informed you are about, prior to the IUD insertion process is like, you are going to have a smaller uterus, it hasn't had a baby yet, and so going over those different options would make sense for them, and choosing one. So I won't go over like certain brands.
Your experience so far, are these people uncomfortable?
Yes,
So why are they not automatically, if you are null parita, why are you not so this past year, the CDC finally, this year, declared that pain management for gynecologic procedures, including IUD placement, needs to be considered. Yeah. It's going to be a standard of care. And so if you automatically know, why now?
How long did it take? I mean, that's kind of what the American Journal of Obstetrics and Gynecology advocates for the consult first, right? Like really getting to know the patient so you can prepare for that procedure in office if it's going to be successful, so the patient feels most comfortable. That's addressing anxiety, of the procedure, so lorazepam, diazepam, some of those things if they're appropriate, making sure
that also means they have to have a ride.
Yes, yep, and these should be like fully informed conversations, right?
But sometimes it's not even anxiety. If you're talking about a null parita person who comes in chill as a cucumber, but the truth is their uterus is gonna
Well, but I also say if they are, I advocate for misoprostol. Because that helps.
That's the softening.
Yep, softening of the cervix.
She's gotta use big words here, people.
I know, sorry. You insert into the vagina closest to the cervix as possible 8 hours prior to that procedure.
Right.
Okay, and so then an hour prior, you have naproxen or ibuprofen, 800 milligrams. And so, again, there are steps before even the IUD, should be taking place, And
Right.
so kind of going back to that question, though, I have some patient or providers who prior to the American Journal of Obstetrics and Gynecology submitting this like formal thing is that they wouldn't give an IUD unless they were on their period, and that's because of that natural dilation aspect. But it's because we weren't given guidelines, we're trying our best.
I find that I was
weren't.
more sensitive during my period,
Yeah,
so
and
that
could
actually
be the
ended up
case
being more
too.
painful.
Yeah. But I think also like your IUDs can be helpful for during different symptoms, including like perimenopause, and I mean,
And mine's progesterone only, and I do think it has helped me, but I likely will miss my menopause year because I'm not having a period.
Yeah.
So
on average, people can still have symptoms after your menopausal, anniversary date, or like that.
But if my
that
diagnosis, if the diagnosis for menopause is 12 months without a period, right? I haven't had a period like in 12 months, but it's because I have a progesterone only IUD.
But that's when they can check your hormones, right?
Yeah, but as she mentioned,
so birth control can actually alter
right.
your levels.
So how do you even know? I could be in menopause and don't even know it, right?
Yeah, but I mean, sometimes it's helpful to leave these in, and you can talk to your provider about this too. It's like the extra progesterone to protect your uterus in consideration of estrogen. It's technically an off-label use, but maybe you need a little bit more progesterone, and that little IUD has helped thus far, and you can keep it in. There's no harm in keeping it in, as long as it's in the right place. And so it actually like breaks my heart, because from a practitioner side of things, like as a woman, you always want to support, and give them the option, and make sure they are the most comfortable.
The truth is they were literally providing hysterectomies because women were acting hysterical.
Yeah.
And they thought that the uterus, hence why it's called a hysterectomy for hysteria, was being removed. Just so you know. Also in England at the same time, they would actually, like, you would send your wife to your doctor to...
get treatment.
No, like, to give her an orgasm. Because it would make her better.
Well, my word. Anyways, continue.
I'm just saying.
I mean, also
this is the way we look.
addressing the orgasm side of things. I think another symptom of like menopause is not women. First off, like they don't realize that your clitoris actually shrinks, right? So decreasing.
Well, your vagina shrinks.
Yeah, everything, and so.
Yeah, we don't say it we don't say it shrivels up for no reason.
Well, so I know. But I think the idea is taking away that stigma a little bit to really address concerns, because women don't come to me like, and they're like, I can't orgasm, I'm so dry, I think it's just because I feel like we feel comfortable talking about right now,
Wait, women, you're saying that women don't walk into your office and they don't say that?
They will, but sometimes I have to pull it out of them because I'm giving them the floor or the space or permission sometimes to talk about it. And then once you're starting to pull on this, like, hey, are you having this? Hey, are you having that? Then they're a little bit more like upfront. And I think I love that they are upfront about this because that means we can address it, right?
Wow, yeah.
And so I think that's really important because it's not just lube. I get so annoyed because these poor women are trying, they don't come into me saying they haven't done anything.
Yeah, some doctors tell them.
Which is horrible because there's lubrication
lube
during intercourse, right? There's moisturizers, and then they have estradiol. But, like, also treating the underlying thing, estrogen,
A lot of people don't make this reference, but I actually learned this in aesthetics, that our genital area ages just like our faces do.
Yes,
so they're actually very similar.
A skin routine.
Yes.
Like, think of it as a skin routine just for a different area.
Right,
and people kind of giggle at it.
So you're advising
like,
people to do a skin routine down there. Oh, wow.
Because I think about, like, okay, lubrication during intercourse. Great, not helpful. Let's do vaginal moisturizers every other day, like 3 times a week.
Do you have a recommendation?
Yeah. It's like, and then
serums down there.
Yeah. And so
Because when I spray deodorant down there sometimes for that stank I get, it's kind of like, oh.
But us women
I don't know
are
if
like
that's supposed to be
mass
done.
marketed to sometimes, right?
Yeah.
And so I think it's this idea of
We just came up with a new business, y'all. We're going to start a skincare routine for your genital area.
I think it, but not enough women are addressing it, right?
There's
Like,
anal bleaching. Why are we not talking about, vulva rejuvenation?
yeah,
right?
well, and so then we just call all that area the vagina,
It's not
and
the vagina.
Yeah, and there's
the vagina's
so
the
many
shaft.
other parts,
Yeah.
and so we
labia majora, labia
yeah,
minora.
let's go through it a little song.
But vulva. I like vulva.
But they have the estradiol cream,
Yeah.
a lot, and then we talk, I personally, I also highly recommend pelvic floor physical therapy. I don't think enough people talk about that.
And right after pregnancy, right? Or
Right
something?
after pregnancy, during pregnancy, perimenopause, menopause, we have a
'cause
lot of urinary symptoms.
I think that's something else that people don't understand. That again, if you're losing muscle mass as a woman with aging, if you're losing skin integrity as you age, that your pelvic floor is carrying a lot. It's carrying it is holding up your cervix, your uterus. Your all your bowels.
Yeah.
I mean,
Gravity's not our friends anymore.
No,
And
exactly.
so we're trying to
Exactly.
really
I think
address
as you get
those
older,
muscles.
like our ages and older, we're still young.
Yeah.
That you'll start having those urinary symptoms. I think
Yeah.
that come along so often.
Yeah. And not a lot of people
Our
wanna talk
family
about
is
that
actually
even.
predisposed to pelvic floor incompetence, I would say. And I say that because our mother had a hysterectomy in her 30s, and she
She's very
actually
young,
had she was diagnosed with a cystocele and a rectocele, which means collapse of the areas that hold up your urinary as well as your rectal.
Bladder,
tone.
cystocele,
Yeah,
dropping
yeah.
down. And that's a lot of people. People
Then you
say I
get-
have a prolapse. There's different types, and this is also education and stuff like that. Because once you know this, it also helps the pelvic floor physical therapist or occupational therapist really address your different.
There's different
symptoms.
types of Kegels.
Yeah.
It's not just one type of Kegel, and
Yeah,
a lot of
some
people
people
don't
don't
know
even
that.
know how to do
There's
a
butthole
Kegel.
Kegels.
Yeah.
Like if you're holding in a fart versus holding your pee versus clenching in the middle. There's
Yeah.
3 different types.
Yeah,
Right.
well, and so I always say it because I feel like I'm a salesperson sometimes to my patients because I really am trying to advocate for them. They don't know anything. They've never heard of this. What does this mean?
Because they say Kegels.
Yeah, Kegels is a cure-all, and that's my
But
biggest
no,
pet
but they say
peeve.
Kegels
That's what
as in
I'm
it's
saying.
one type, and they literally look.
We are trying so hard to address these different aspects, and so local estrogen can help with these things, right? And so estradiol cream is a great option, especially because you can apply it to where you pee. And not enough people know that. We just they use the applicator, they insert it, but with these different things is if you're having urinary symptoms, apply it to the place that it needs it. The urethra, maybe the vulva, then the vagina. We just say the vagina and they just shoot it up there. And then so the thing is you can also apply it with your finger, right? Not a lot of people are talking about these different ways of administration. And then if the cream's I usually say do it at night, let it do its thing, all this different things. But if they don't work for you, have that conversation, right? Keep going, keep advocating. Okay, let's try a tablet. Let's leave it there. Let's see if that helps. What about E-string? And this is hard too, but I'm saying these different things because there's so many different methods. Let's find a method that works.
Well,
for you,
isn't
right?
oral estrogen actually absorbed ineffectively? Really, your transdermals or your are a little better, more
to
efficient.
address that too. Is so it's actually safe to use a localized estrogen. We say localized estrogen is safe enough for breast cancer survivors now, which is really great because
But get checked out with your doctor first.
Yeah, of
yeah,
course, yeah.
absolutely. And so get that okay from your oncologist. But there's new studies that say that it is safe. It doesn't increase your risk for reoccurrence. And these poor women have gone through, trying to stop
They
their
take
hormonal surgery.
estrogen blockers.
Yes, exactly.
And
where that area is
yeah.
most affected, or it's unfortunately the vaginal area. So
Yes,
let's treat that localized.
Yeah.
Let's not. I think destroying the stigma of suffering, right? We
That's
should not
exactly
allow that.
yeah. I think that's exactly it. I think too often we're talking about women who are just again grinning and bearing it, and I think that's such a disservice to ourselves as well as to our patients as well as to our daughters or yourselves that you could come up. I think the general gist of this podcast is we have to advocate for ourselves and we have to start pushing these narratives just for example, 1.1 million research articles have occurred on pregnancy. So you can see where the priority is there, compared to only 97,000 for menopause. And by the way, only 6,500 for perimenopause. So if you want to talk about where the priorities are placed in women's health, it is on pregnancy. It's not on these other stages of our lives. And we have to understand that studies inherently have disregarded women. So many studies out there have been done on men and not women for all different kinds. And let's be honest, up until recently, did you know that tampon absorbency wasn't even being performed on actual period blood? It was being performed on red liquid. So the absorbency rates of these tampons, like total disregard for how effective they are. And so you're bleeding through your tampon and you're thinking, God, I mean, my flow is so heavy. Why isn't this tampon working? I'm using supers. So besides IUD placement, which I obviously put out there as a discomfort, I know, Christine, with your recent rotation, you can kind of to attest to this, but colposcopies. So, I kind of started this podcast by talking about scraping out somebody's uterine surface, but that's basically what you're doing with some of these treatments. And even you said that you went in for an IUD and they were literally scraping, your uterus.
Well, so
you don't have to get into that, but you can understand how uncomfortable that can be.
Absolutely. And I think that's why I have a lot of empathy for my patients in a lot of ways, is being a woman and trying to make sure I can make my patient as comfortable as possible. Like a biopsy of the uterus, endometrial biopsy is very uncomfortable. And then colposcopies, when indicated after a pap smear, for it's a procedure where we take a biopsy or take a closer look on your cervix. It's really, again, addressing and having that conversation with your provider of, your anxiety around it. Make sure why you're having the procedure. Just education is knowledge, or, is really powerful in that sense, too. So,
but do you really think that some of these procedures, I understand that some people seem to tolerate them okay. I mean, obviously a paraplegic's fine. Right? Yeah. But why? I mean, I just am shocked by the level of stories. I hear about breast biopsies. I'm sure you can probably attest to this as well, where women are in there and they're digging around and they were supposed to be localized and they're placing these markers and they're literally in pain. Yeah. And they tell these stories. And again, it's I will tell you that when I do stuff with patients, I'm watching their facial expressions and I'm are you doing okay? I'm always checking in with them. Do I need to change something? Do I need to lay the bed flat? Even when my daughter was getting her IV placed during her, for her surgery that she had, I was watching her and I watched her go, she said something why do I feel that in my head? And that's when I realized that she was actually vageling. And I stood up and I lowered her bed on her stretcher. I recognized that she was vageling and they hadn't really, and no disregard to them, I mean, but it's those little things. We're just watching your patients, watching them for signs of discomfort or, I can't tell you how often I hear these horror stories. And it was me, again, having my IUD and being annoyed and knowing that there was options. Because I knew that they could have done a paracervical block. I know that men can get a general anesthetic for a vasectomy because I've performed them. But yet we're being forced through these biopsies. And honestly, I get these patients for mastectomies or, in the operating room, and they're coming in and they're telling me the stories about how, I don't think the local worked, or they're telling me how it was one of the most painful things that they had done. And if it's a rare occurrence, then we wouldn't be hearing it over and over again. And it's not a rare occurrence. And the problem is that we have got to stop accepting, we need to be no, that hurts, stop. Can you make it more comfortable? But instead they're oh, are you, they may not even ask. They're so focused on doing the procedure, they're not even paying attention. And even if the woman does say something, they kind of disregard her because again, they've seen the women wince. They've seen the women jerk. They've seen it and they know that they can get through it. And they just...
I just think you have to be cautious because things that you might do for intervention might also have side effects. So you were saying general anesthesia. I think that's so much, but
No, I'm not disagreeing, but the truth is that you can localize. I work with so many surgeons who are amazing
take
at
the time.
localizing the area, but also allowing the local to work.
Mm-hmm.
We all know bupivacaine takes a little bit longer. Lidocaine's fast, but guess what? Lidocaine isn't instantaneous. It still takes 2 to 3 minutes. And that's, again, where you've localized it first. You have to let it spread. Anyway, every drug has a peak, which means that at its absolute best, and then it starts to wear off. And if you're having difficulties, and I think this happens sometimes in these procedures, if you're having difficulties with anatomy or the patient cooperating, these locals will start wearing off. And some people do localize, but then they metabolize quickly. So I will even ask people for different types of procedures that I perform, do you ever have to ask the dentist to add more local? Because oftentimes those people, if they say, yeah, every time I go, or, sometimes it can just be poor procedure, but most of the time it is that they require more to get comfortable. Everybody isn't the same.
Yeah.
Are you a redhead? Are you one of those people?
Yeah, that's what
Yeah.
I'm saying. Like, I always need the extra, pain medication.
So there's a gene associated with redheads. Not every redhead has it. It has to do with this gene that's in the liver called CYP450, and they have elevated levels of it, which means that basically, think about it this way: like if you were walking into a store and they had 100 dresses that you wanted to buy, there's 100, like you have all day, right? It's probably a bad metaphor. Anyway, the point is that they just chew it up really fast. They have like all these things, they just chew it up really fast. So as soon as you're giving it, they're already breaking it down. While some people have low levels of it, and then they those are people who take forever to wake up from anesthesia. They just metabolize so slow. They have very little low levels. But so I think the truth is that there's too many procedures being done on women that are uncomfortable, and sometimes we downplay it too.
I guess we can kind of touch on that too a little bit. Is self-advocating is so important because not every woman's the same either, right? Like, I'm talking from a ginger perspective, but what about women of color, like Black women, especially? We should address their pains, levels as well, because there has been disparities shown in research that their pain is not fully addressed. And so I think, again, going back to it, we really need to advocate for ourselves, advocate for the patient in these positions, and even endometrial biopsies, we kind of touched on that before, they have we really should be considering different regimen or indications for them as well, and postmenopausal bleeding and stuff like that. So I guess what I'm trying to really drive in this is self-advocating, and
there's no award for grin and bearing it, right?
Yeah,
you don't get an award for saying,
tolerate it.
I was
suffer.
in pain.
Yeah.
Yeah, exactly. And I think that we have to start anyone, if you're having pain, just be like, no. Like, if you say no, your provider should not be continuing. Like, they should be figuring out a way. And sometimes it means rescheduling your procedure. And I've had people say that. I'm like,
And
if you don't
that's
think you can do this today, then we
I
can
think that's
reschedule you.
important.
I do that with cataract surgery a lot. I tell people, do you have any questions about the type of anesthesia I described to you, or do you have any concerns about your ability to do it this way?
Yeah.
Because it is conscious sedation. You are awake and cooperative. And I have some people who are like, well, I just want you to knock me out. And then I say to them, general anesthesia is an option, but it's not an option today. We have not,
people.
and we have not. When it comes to
But
surgeries,
if it makes them
sometimes
feel more
anesthesia is
comfortable,
longer. Yes,
fine.
Then you can
I
have
think that's
yeah.
the thing too. Is in any procedure, I will say before the procedure, if it becomes so uncomfortable and you need me to stop, that is fine. You're just going to tell me, and then we're going to reschedule with the doc, because I'm only a PA, and we can do it in the OR.
Yeah. And that's every person's priority, prerogative, and this has to do with their priorities. For me, it's like, no. Like, give me something. I'm not dealing with this. Local anesthesia is pretty benign. I mean, unless they inject too much, it really is pretty benign. So give me some local anesthesia.
At least,
yeah. So let's talk about steps in advocacy and kind of wrap this final thoughts up for everybody. What providers can do. So we would all agree better communication.
Yeah,
Right?
I agree.
Training, which we talked about. I think in order to really specialize in these specific situations, I do think that people have to go back for training. I'm talking to Christine right now about potentially doing a menopause certification because I want her to have the knowledge to actually, but I was talking to Taylor that knows somebody who took the certification.
The Menopausal Society, certification, which you want your providers to be as educated as possible, which is great. But the test that she had
only had 3 questions.
3 questions about HRT, which is like really disheartening in some ways. Not to say that that they're not coming from a good place, but I just think like being graceful, with your provider too. We want you to feel better, safe, in safe areas, and so having these conversations, really addressing what's most important to you, is really great. Knowing also like I don't know how you guys do it here, and you could probably advocate for it too, but I think the idea of maybe starting on progesterone, knowing how it's working for you for a week prior to initiating estrogen, whether or not that's oral versus a patch versus injection, because we don't even talk about those, like all those options, is really important. Like, what's going to work for you, by the way?
Right.
What's safe for you?
Right,
Going over those.
Well,
And
obviously,
so,
in some cases, like obviously, some of the symptoms are coming to us are progesterone or estrogen-related symptoms. But for people who come to us saying it's libido, it's testosterone. Yeah, exactly.
And
so,
there's different brand and so routes and stuff you can.
Exactly. And most people, like when it comes to
What you offer
testosterone,
here
they
and
don't
stuff.
want to do a weekly injection, especially women. And of course, men, they don't always want to do a weekly injection. As we kind of mentioned, men are kind of wimps. So if they don't have to do a
It's
weekly
amazing what women will do.
injection, I know,
Like how I
yeah.
think again our strength, right? What we're willing to do and stuff like that is really important.
But we can't just accept it. I
Yeah.
think as women, we can't just say, I'm surviving being a woman.
Yeah.
I'm surviving. Because I talked about this when it comes to growing old, is that there's a difference between a quality of life and a quantity of life. And the truth is that do we want to live to 100 but be miserable for those 100 years? Or do we want to live till we're 80 and have the best 80 years?
Well, I think that about HRT, and I keep going back to HRT, but again, just talking about women we're told, I mean, certain providers don't feel comfortable prescribing past 60, and so this idea that there is an increased risk, you have to talk to your provider about that and going through those options and knowing if you feel comfortable with that. But we shouldn't have to take them off HRT if they're still healthy enough to be on it and it's helping their quality of life, right? I mean, I have some women who are still on transdermal and they're in their 70s, and so I feel like, just kind of discussing this, make sure you're having these conversations because quality is so important, and also being real with yourself and how much that's affecting you. I think it's important too.
Well, that's the survival part. Like,
Yeah.
I'm just going to get by. Like, you're like, well, I don't want general anesthesia. I'll just deal with the pain.
Yeah.
And again,
That's okay for you.
That's okay
Yeah.
for you. And if you're okay, whatever you're okay with is okay. And whatever you need is okay. Now, I will put a little asterisk by that statement, and that I do believe patients should advocate for themselves, but sometimes people, the Google doctor, Dr. Google, can be a little bit. I do love when somebody comes to me informed. I tell them,
they try to research, they try to
I'm
become
so
educated,
glad,
but also
but don't-
allow that interpretation from your provider to explain things
Exactly.
or or
don't disregard. Like,
Yeah.
again, if the provider is saying something that you know to not be true, sure, maybe they have it wrong. Maybe they're not as
or
educated
keep asking
in it.
these questions to
Yeah.
really determine if they feel comfortable in this conversation. Do you feel like they're well educated in this? And
And it's okay to be like, I'm going to go get a second opinion, or I'm going to find a different doctor. Yeah.
And
Find your
honestly,
fit.
as a provider, again, I want you to feel comfortable.
Yeah.
You know,
I don't
like
wanna take care of
personalities don't always
Right.
mix. As much as I try to be friendly or like allow these conversations, it's okay to self-advocate.
Yeah.
We want you to. Like, it's
I don't
really
want to
okay.
take care of somebody who doesn't want me to take care of them.
Yeah, I agree.
I don't want to.
Yeah.
I've had somebody say, well, you're just a nurse anesthetist. You're not a doctor. You're not an anesthesiologist. And I'm like, You're right. And for that reason, if you need an anesthesiologist, then we won't be doing your care today.
Mm-hmm.
Like you have got to, like, I'm not
Mm-hmm.
willing to set myself up for, a potential complication and for you
Mm-hmm.
to automatically assume it was because I wasn't a doctor.
Mm-hmm.
Like, I do anesthesia. I've done it for 15 years. I've never lost a patient on the table. And I will stand by that, that I am more than capable and competent. And that I know CRNAs who aren't great at what they do. I know anesthesiologists who aren't great at what they do. And I know PAs and NPs, I mean, the truth is every specialty even outside of medicine has people who are great. I mean, one artist, can paint a painting and you think, I don't know, it just happened there. Right.
Yeah.
And then another artist can move you and really, is beautiful.
You can see the skill.
Yeah,
exactly.
Exactly.
You don't even want to attempt. Yeah,
exactly. So, I mean,
it's that respect.
Yeah. And the truth is that some parts of medicine are an art. I would say anesthesia in some ways is, obviously aesthetics is, but I would also say that there is an art to managing patients, and that can't be disregarded. There's an art to, kind of picking up on things, the intuition. But even if you pick on something, you have to be so careful with how you talk to patients. I just find that,
Yeah,
how
well,
you say
giving
stuff
them the
matters.
space to talk is definitely the home message, I think, too. And I think especially your business, like, you really want to address what their highest concerns are, right? Again, and so
Yeah, and we definitely, when we have patients come in, we're always like, go speak to your doctor, let them know that you're doing
I mean, don't you guys
this.
actually have a consultation room?
Yeah.
Like, let's just consult. Let's
Yeah.
just talk.
I mean, that's
like,
exactly
I
it.
think
We
that's
tell
important.
people we do require a deposit for the appointment, just because if for whatever reason they don't show up, they've just blocked out an hour or more of our day.
Which is great. You guys have an hour.
Yeah, because we're concierge. We're not dependent on. We don't actually do any insurance here, because I just think insurance gets in the way of patient care. To be honest with you, but the truth is that we do not charge for it. That deposit is non-refundable, so it sounds like we do. But the truth is that you're making that appointment in good faith that you're going to come and have that appointment with us. And that $100 can go to whatever you want. I mean, like, you can, get some Botox. You can, you can get a facial. You can buy some skincare. There's something we're going to provide here that will benefit you, even if it's not even medical. So it doesn't have to be a medical procedure. So that $100 will never be wasted. We don't want your money if you don't want to spend it here. But at the same time, like, you are still taking up $100 worth of our time, right?
Yeah.
We're doing it for free, but we want you to take care of yourself. But yeah, we definitely take the time. And honestly, I'll be honest, I know fundamental practitioners who charge $400 for a consultation. They charge it. These concierge services, I actually was going to go get like a workup, and it was like $495, and I was like, it's just for the visit, the one visit, And then there might be labs, and there might be follow-ups,
wasn't
and
even
then
any-
yeah. And in some cases, they might use insurance, like after the fact, like for labs and things like that. But that consultation is cash-based, period. Yeah. And I explain that with physicians who do injectables. Actually, a physician expects a certain amount of revenue in an hour, and so some of them have a 50-unit minimum. You have to get 50 units because it doesn't make sense for them financially. They're going to spend 20, 30 minutes with you, and they're only going to do it if you spend this amount of money with them, and that's why a lot of plastic surgeons hire injectors, because that injecting, the revenue just isn't worth it in a lot of cases. Now, some charge a lot of money, but again, not everything is what you pay for, right? So, well, let's kind of wrap up today and kind of finish up what we're talking about today. We've done a really good job, I feel like, touching on a lot of aspects of women's health. I think we have to keep advocating for our patients, ourselves, and women's health in general, for all cultures, for all ethnicities, and keep asking the questions, right? Why do I have to do this without anesthesia? Why are you doing this? And saying no and walking away from scenarios in which you're uncomfortable, because without these conversations, without us standing up for women, then nothing will change. It took over 100 years for IUDs to finally offer local anesthesia. And so I'm glad to hear that that's the way that the things are turning. Same thing with HRT and women standing up for their changes they go through in life, whether it's for postpartum, perimenopause. I want us to change the script. I don't want it to continue to be grin and bear it. I want it to be an evolution for women's health in this country and around the world. So I hope that you learned something today. I hope that you're willing to advocate for yourselves. We'll catch you next time on Shift Happens.